Today, we're going to be talking about ACL sprains or tears, and it means the same thing. A sprain, a tear, a rupture. It can be a partial rupture or full rupture. We can grade those out, but at the end of the day, it all means the same thing. It is a ligamentous injury around the knee, and it is relatively common, so you should understand this condition very, very well. So a couple of key things that we should get: partial or complete tear of the anterior cruciate ligament, the ACL, and this is inside the joint capsule. The ACL is the primary restraint for anterior translation of the tibia in relation to the femur. 85%. Now I'm going to show you a cadaver video here in a second that shows some of the other structures that maintain it, but its greatest restraint is in full extension. So when the leg is straight and we're in that tight packed position of the knee, we should be aware of that. Also, secondary restraint for valgus and varus forces, and even twisting forces. If you do any jiu-jitsu and you know about heel hooks and things like that, you actually wind up tearing these ligaments apart potentially in those holds. All right, so injury occurs following repetitive microtrauma or repetitive overuse, or a combination of both of those, followed by sharp or sudden change in direction, cutting and twisting. This is also the same mechanism for meniscus, but we'll see how it's a little bit different and fairly obvious to get. I love knee injuries. They're easy to figure out. They're easy to go ahead and rehab. Imaging is great. You have lots of options available, and you can help a lot of people with those different options. So ACL failure has been linked to heavy, stiff leg landing, especially if the knee is in a valgus position. I would suggest to you, if you are also of female persuasion, you may also see an increased risk of rupture as well. Incidence: 1 in 3,000 per year, 200,000 in the US every year. This is a common injury rate here. And if we look closely, we can see the ACL on an anterior view, and then this lateral view, that is the ACL. So you can see how if you pull forward on the tibia, so move that tibia anterior, it would stretch that ligament out. But also remember, when the knee is in full extension, that is a tight packed position for the ACL, and it may also be damaged there as well. Female, 4 to 6 times greater risk compared to men. And there is research supporting, depending on where you are in your menstrual cycle, you may also have an increased risk of this ligamentous rupture as well. People with ACL tears have twice as likely to have a relative with an ACL tear. There is definitely a genetic predisposition, poorly understood at this time. Risk factors: female, possible hormonal factors, late in ovulation period, yeah, sure, may have anatomically smaller ACLs. This is something we see in the literature as well. Women tend to have smaller ligaments than men on average once you actually look at the same size and body weight male versus female. Contact sports, soccer, basketball, wherever you're wearing cleats or have high torquing forces on the knee, you may see increased risks. So gymnastics, skiing, valgus or hyperextension forces. If you have a client or patient who comes in with a hyperextension or a recurvatum of the knee, genu recurvatum of the knee, where they have more than normal extension, they could also be at increased risk. It is associated with ligamentous instability of the knee, laxity, poor conditioning. If you have weak muscles that also can give you some force and absorption here that aren't working correctly, it can increase the load on the ligaments and therefore increase the risk of damage there as well. Muscle imbalances in the hamstrings, especially cleated footwear, we've already mentioned. Anywhere you have performance enhancing shoes that make you run faster than you can. I'll just step off here for a second. If we had people actually running around barefoot, how we are designed to run, you would see the rate of knee injuries is substantially lower. And I'll give a prime example of this. I do these things called lift and learns at lunch with a number of my students, where we're all adult students and we're out running around and doing cutting drills, playing tag, even soccer barefoot. And you cannot believe how much harder it is for you to pivot and turn when you are barefoot. Instead of actually being able to grip and pivot hard, your feet just wind up slipping out. And that slipping out would be the loss of energy as your body moves into a different position that gets absorbed into your knee when you have cleated shoes. And especially if you're playing on a artificial turf as well, the grip is even harder. All right, what else do we see? So what is your assessment going to look like? It is going to look like deep pain following the trauma. The person is going to try and reach inside of their knee. They may have heard a snap or a pop at the time of injury. They may also have less pain with a full rupture. And this is well documented right here. Partial ruptures, the fibers are still attached. So when you go to do a pull on it, it actually causes more pain perception. But in a full rupture, the fibers have moved all the way apart, and now those loose fibrils and nerve endings aren't in contact. So you don't get as much of that mechanical stimulation to actually give the sensation of pain. So important for us to be aware of that. Knee swelling is usually noted within 2 hours, I should say. It may even come on quicker than that if they've ruptured any significant vessels or have another coexisting injury that occurred with it at the same time. ACL injuries are often associated with this unhappy triad: ACL, MCL, and medial meniscus. But don't close your mind to this. There is also research out there that says you can have other damage as well. PCL injuries occur quite commonly with this. You can have lateral meniscus tears. All of that can occur now too. Well, should be in your brain to do a full evaluation of your client or patient. Inspection, look for joint effusion, bony abnormalities. Potentially, you might see a step defect on the top of the knee or excessive motion, antalgic limp with ambulation for sure. In the absence of bony trauma, immediate effusion is believed to have been a 72% correlation with ACL injury. So if they don't have like contact sport injury, or your risk of fracture is low basically, and you see swelling inside the knee, or it's swelling outside the knee is how we'll observe it, 72% correlation with an ACL injury. Very, very common. Examine joint lines to assess for meniscus. Remember, your main finding for a meniscus tear is joint line tenderness with a planting twisting event. 50% of ACL injuries are associated with meniscus or other collateral ligament damage. So please do a detailed evaluation. Active range of motion, passive range of motion will be limited to an extension due to pain or swelling. You might have a boggy end feel in there potentially. And resistant range of motion might be within normal limits or may be limited a little bit due to pain. That can vary a little bit. Neurovascular should be within normal limits. However, if you have changes in the nerve structure, that can indicate other injuries. So still worthwhile doing a super quick neuro and pulse check if you want to make sure you're covering all your bases. Differential diagnosis is going to be fracture, tibial plateau fractures are probably going to be most common, or an avulsion fracture of the medial or lateral intercondylar eminence could be there as well. Patellar ligament or patellar dislocation. Meniscus or collateral coexisting injury. Rule out hip pathologies in children. If you watched our videos on the hip pathologies, leg calve Perth, slip capital femoral epiphysis, transient hip synovitis, and even septic arthritis could all potentially refer to the knee. So when somebody comes in with a limp, make sure you are doing a hip evaluation. All right, keep your special tests simple. Anterior drawer is a great test. Lever test is a great test. These have good research. Lockman's also a good test where you're looking for anterior and posterior translation. Of course, you are checking the unaffected side first and then coming to the affected side to get a baseline of function. Anterior drawer, one thing you do have to watch, and I would strongly encourage you to do it this way, is if you look at this image, you can see that my fingers are palpating this athlete's hamstrings. This is the amazing Dr. Charity Hess, who has incredible hamstring strength. And not for her, but I've got other professional level soccer players come in, confirmed on MRI, full ACL rupture, yet when you go to try and pull their legs forward, you can't move them at all because they have enough stability from their hamstrings and other ligamentous structures around there. So they show pretty stable knees, very difficult to move. That's why I would put my fingers right here on the hamstrings to see if they're hyperactive and maybe holding that knee from translating forward, because that could give you a false negative potentially as well. So range of motion in that anterior drawer, what are you looking at? If it's less than 5 degrees, mild, grade 2 or moderate is 5 millimeters, 5 to 10 millimeters. And if you're over 10 millimeters, that 1 centimeter mark right there, then you're looking at that severe injury or more significant translation. And again, thumbs go into the eyes of the knee right here because you can actually palpate the tibial plateau and the femoral condyles to actually get a good assessment. Now, if there's lots of swelling, it's going to be more difficult, but you can usually push the fluid out of the way with your thumb. If you are lost on this test, you can also watch all of our videos on all of these special tests, and we'll show you how to do it as a smaller practitioner, larger practitioner, and also the basic muscle testing you do in that area as well. Diagnostic imaging, Ottawa knee rules are going to be there to rule out fracture. And this is your basic fracture screen that you would follow. So over the age of 55, history of significant trauma, dark black bruising, pinpoint bony tenderness, inability to flex 90 degrees, failed 4-step test. All of that probably warrants imaging, would be a good idea for your patient. MRI is the gold standard, although ultrasounds are quite good as well now if you have a good quality ultrasound unit. But what are we looking for? 90 to 98% of ACL tears will show up. And here I've just drawn it out, so it's super obvious for people to see. Will show up on MRI. If you don't have that available, ultrasound is a relatively cheap, quick option that's readily available is too. Should not replace a detailed history and exam. And I can't stand this. You'll see me post on my Instagram every now and then. ER docs, especially, they're not doing, well, I'm generalizing here. A lot of doctors will decide that they can't do anything until they've actually had imaging done. Well, that's not the case. If a detailed history and physical exam will give you most of this diagnosis. I do want to take a step back because a lot of people think about knee stability and all they think about is the knee joint itself as the ACL providing that stability. And I want to play a cadaver dissection video so you can see the layers around the knee here. So I'm just going to bring this in and make this a little bit larger here. So this is a dissection of the knee. I'll probably turn the volume down and you'll watch how this person moves. So what's been removed here only has been the skin and adipose. And in fact, still some of that is actually still there. So it's just for basic orientation. This is the patella at the bottom. If we look here, we can also see the back of the knee. So popliteal fossa. This is gastrocnemius and soleus. Should let this play. Gastrocnemius and soleus, and then this will be back up into the hamstrings. Now, of course, this is a geriatric donor, so they're relatively small. Iliotibial band coming down the side, continuous with the fascia lata that wraps all the way around the thigh. So when you're working on a thigh, it's not directly into muscles. You have thick fascial membranes there, and they create some of the stability. We also have thick fascial membranes down on the front of the tibia, which we'll see later on when we talk about our compartment syndromes, that muscles actually attach to. So again, your whole lower limb is wrapped in thick, dense fascia. And when you move, you can see that the iliotibial band stretches out, but this fascia is so strong, it also creates some of the stability around the knee. And if we peel back this fascia, guess what? There's another layer, and then there's another layer. There's about 3 layers before you get to the medial and lateral collateral ligaments that we all talk about as major stabilizers. So I would encourage you to realize the fascia is also a major stabilizer, and so is so are the other layers of membranes and the muscles around that area as well. So kind of neat for us to see there. That's me just showing a valgus and varus stress test. And again, this fascia resists that movement. Now, this is a fixed donor, so not quite the same as unfixed, but again, you could see when I stretched out there, let's go back again. Just this little bit here, you can see, watch the fascia right here in the center of your screen. You can see it stretch out and resist me doing that action. Still a major stabilizer of your knee. So don't forget that. Too many doctors, too many therapists just see ACL, PCL, MCL, LCL, and that's it, when really there are many more stabilizers around there. All right, so, but your imaging is going to be a good choice, and ultrasound is also going to be a good choice as well. So management, biopsychosocial support. Realize for a lot of athletes, this can be a very fearful injury, and they may believe that this is a career-ending injury. Usually it's not, depends how bad it actually is, but you wanna make sure they have the right support through counseling, empathetic doctors and therapists who are on their side, so we're all working together to get the optimal results for this patient. Education, empowerment, exercise and action, and then into our manual therapies. So when we go into our manual therapies, one of the key things that we can look at here is massage is going to be good. All areas of compensation, you can relax the muscles a little bit, even lymphatic drainage to move fluid around inside the knee. Patellar mobs might not be a bad idea to start again moving fluid, right? Remember, inside of that knee joint, there should be no blood. So the only way you're getting nutrients back and forth is through movement of the soft tissues in and out of synovial fluid. So you want to try and promote that as much as possible, as long as you're not re-injuring. In chronic cases or more longer term or non-acute, you can move into things like meth, get them on the drugs of movement, exercise, traction, and heat. Stripping compression. I'm a big fan of passive range of motion and instrument assisted techniques. Also, osseous mogues may not be a bad idea as tolerated. I wouldn't really tug in the direction of the ACL too much, but light pulling might not be a bad idea, because those gentle pulls are giving signals to those fibroblasts to lay down collagen along those lines of stress. I'm not pulling so hard that we're breaking it loose again, but I am pulling enough to give it a good challenge, and with our range of motion, giving it a good challenge so the cells know how to lay down the collagen to create a better quality ligament. What else? Short-term and very short-term NSAID use. You might consider Prolo or other injection therapies, PRP and stuff, in later stages if you've tried other conservative management techniques that haven't worked. Surgery may be indicated in severe tears if you can get the surgery done relatively quickly. So that'll be a reattachment. just so we're clear on the natural history of this, if you have a full rupture, if you looked at that full rupture about 2 weeks later, you would see the ends of that ligament, of that ACL, would actually have been reabsorbed by the body's own inflammatory processes, and it's very difficult to get it to grow back. If, however, you're an elite level player, or you, for whatever reason, had access to surgical interventions right away, we do tend to see better outcomes with that. Or you have other options where you can have a graft taken from the patella or from the MCL sometimes, but from some of the hamstrings, or you can even take a hamstring like semitendinosis and even run it through the center of the knee as well. Again, this will be co-management with an orthopedic surgeon typically that will give you their selection for outcomes that they like and why they prefer those surgeries. But again, educate your clients on this. What are the benefits? What are the risks? Rehab program, start with core stability exercises and then work through passive pain-free range of motion. And again, not truly pain-free, but mostly pain-free. A little bit of pain and discomfort is okay, but you just don't want to overdo it. Aqua aerobics might not be a bad idea. Open chain movement. Key goal is maintain full flexion and extension of the knee. And in fact, a lot of surgeons and myself, we will use, can you give me full flexion, full extension of the knee as a tell to see how well that knee is actually doing. It should have at least 120 degrees of flexion. Even beyond that shows better outcomes. Prevention, quadriceps and hamstring strength. Back to this image right here. Your hamstrings support directly the action of the ACL. So you want to have good hamstring strength. What else? Proprioception function are key for prevention. Absolutely. Balance, wobble board, light return to activity. Definitely. 50% of moderate tears progress to full ruptures. How does that happen? Going back too hard, too fast, too soon. This is a ligamentous injury. They tend to take longer to heal. ACL surgery has approximately a 10% failure rate, but it depends on the surgery and the surgeons themselves. Key question that your patient needs to ask their surgeons, or if you're there to co-manage as well, what is your success rate and what are the negative outcomes associated with this surgery? All right. And then we're going to go into prognosis. Mild tears respond extremely well to conservative care. 75% of patients who undergo surgery return to their normal activity, functioning, all ADLs without difficulty. So you see good outcomes there. Knee instability increases the chance of progression, development of osteoarthrosis. Yes, absolutely. If the person doesn't get this looked at or taken care of correctly, and they still have a relatively high level of function, that knee is going to be hammering around back and forth, chunk, 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 and that can increase your risk of osteoarthritis, meniscus tears, other soft tissue injuries, and other ligamentous injuries in the area as well. So we want to make sure to rehab this correctly. So that would be a good summary. Some key things that you can do. I am a big fan of squats. If I can get you squatting with good function, or lunges, those are going to be key actions right there. If you want to start off nice and light, some tubing exercises, even just a foam roller, flexion and extension movements might seem ridiculously simple, but maybe a good place to start to build confidence and empower that patient back into more functional activities. So that'll take us through a quick run through of ACL sprains. Fantastic injury. You should know everything about this one. Super easy to identify and excellent for us to offer good benefits with direct treatment or referrals if it winds up being a more substantial injury that's outside of our scope and our outpatient practices. All right. Thank you very much, and we'll see you in the next video.